Thank you for the introduction, and I would like to thank the organizing committee for inviting me. It's a great pleasure. And I will talk about quality of life in patients with acromegaly. Well, this is the outline of my presentation. I will start with a brief introduction about quality of life research in patients with acromegaly. After that, I will tell you something about coping strategies and illness perceptions in these patients, followed by interviews and focus groups, and finally some interventions which aim to improve quality of life. But I would like to start with this picture, and it's a picture of a sculpture made by an acromegalic patient. And she says, well, this left head symbolizes how I felt during active disease. It was like I was wearing a mask. I had a swollen face and I couldn't express myself. While the right head symbolizes the period after treatment. There was less swollenness, she could express herself, she did not have the idea of wearing a mask, and she became more happier. And then when we look at this rock, it's a rough and untreated rock, she said, well, this symbolizes the hard times for my husband and children. But it also symbolizes the support she received from them, as well as from the professionals, like the nurses and the endocrinologists. And I think that this sculpture nicely illustrates the impact of acromegaly on a patient's daily life, for a patient themselves, but also for the social environment, and how important it is to be supported by your environment as well as by nurses and endocrinologists. Now I will go on with quality of life. But what is quality of life? How is it defined? Well, actually, there is not one unambiguous definition of quality of life. There are various definitions. And I brought a few. For instance, quality of life is what the individual says it is. Or quality of life measures the difference or gap at a particular period of time between the hopes and expectations of the individual and the individual's present experiences. Or another one, quality of life is the functional effect of an illness and its consequent therapy upon the patient as perceived by the patient. So as you can see, all different definitions. But I think the common denominator of all these definitions is that quality of life should always be as perceived by the patient. Quality of life can be measured by validated and reliable questionnaires. These questionnaires can be categorized into generic questionnaires, disease-specific questionnaires, and domain-specific questionnaires. Well, starting with generic questionnaires, these questionnaires measure several aspects of quality of life and can be used for several diseases, as well as for healthy individuals. And the most frequently used is the short form 36. And then we have disease-specific questionnaires. These questionnaires assess quality of life which is important, related to a particular disease. And fortunately, for acromegaly, we have the AcroQoL. And then there are domain-specific quality of life questionnaires. And these questionnaires measure one particular domain of quality of life. So for instance, fatigue. That's a common complaint in patients with chronic disease, and this can be measured with a multidimensional fatigue inventory. Here you can see a spider plot of the average outcome of the short form 36 in patients with acromegaly. So we made a review on quality of life research in acromegaly, patients with pituitary disease, and we took all the short form 36 outcomes. And here you can see the physical functioning, physical role, pain, general health, vitality, social functioning, emotional role, and mental health. So those are the subscales of the SF-36, and in this way you can see the profile of quality of life in patients with acromegaly. Using the SF-36, higher scores means better quality of life. The little dots are quality of life during active disease. The stripes are quality of life after treatment, and the gray line represents quality of life of a healthy A-select sample. So looking at this picture, we can directly see that quality of life was dramatically impaired during active disease, that it generally improves after treatment, but that this improvement was not the same for every aspect. So there was a larger improvement in social functioning than in vitality. And in the end, we can see that quality of life is not equal to the quality of life of patients, of quality of life of an A-select healthy sample. And there are various factors identified which influence quality of life in patients with acromegaly. Well, first there are the demographic variables, such as age and gender. And then higher age and female gender was negatively associated with quality of life. There are some treatment characteristics. As we heard today, perceived radiotherapy and medical treatment instead of surgery alone had negative influence on quality of life. And there are several comorbidities, such as restless leg syndrome, clinical osteoarthritis, numbness of fingers, hypertension, sexual dysfunction, and growth hormone deficiency afterwards. So just to summarize these first few slides, what we see is that patients with acromegaly report impairments in quality of life. This quality of life improves after treatment, but quality of life doesn't normalize after treatment. And there are several factors which has been identified that influence quality of life in patients with acromegaly. So then we go further with coping strategies. Coping is the way an individual reacts cognitively, behaviorally, and emotionally to a certain threat. So in this case, it's acromegaly, its consequent therapy, and the consequences related to it. And when we assess coping strategies by the use of questionnaires, and we compare coping strategies of patients with acromegaly and compare them with an A-select sample, we see that patients with acromegaly report less active coping strategies, use more avoidance coping strategies, and that they seek less social support. And then illness perceptions have been studied by the use of questionnaires again. And what are illness perceptions? Well, illness perceptions are the perceptions a patient has on their disease. And then you can think about, what is the cause of my disease? Is it curable? Is it a chronic disease or is it an acute disease? What are the consequences? And which complaints can be attributed to the disease and which complaints can't be? So those are all illness perceptions patients have. And when we compared illness perceptions of patients with acromegaly with patients with an acute disease, we saw that patients with acromegaly have more negative illness perceptions. On the other hand, when we compare illness perceptions of patients with acromegaly with patients with a chronic condition or Cushing disease, they had less negative illness perceptions. But more importantly, we saw that these illness perceptions were strongly related to quality of life. So that was assessing illness perceptions by the use of questionnaires. But illness perceptions can also be assessed by drawings. And these are the drawings of patients with acromegaly, and I will explain it. We ask patients to draw themselves during a healthy state, so before acromegaly. We ask them to draw themselves during active disease, and we ask them in the current state, so during biomedical remission. And what we saw is that the picture during active disease was significantly larger than during the healthy state, but also that the picture at the current state, so during biomedical remission, that it was still significantly larger than the first picture. Furthermore, we saw that these drawing characteristics were correlated with illness perceptions and with quality of life. Well, another qualitative manner of assessing the impact of quality of life is by the use of interviews and focus groups. And it was done by Girl et al. And here are some quotes of the interviews. So a patient said, I've been through a lot of physically, emotionally. Acromegaly has taken over and changed my life completely. Or another quote, since becoming ill, I've lost my career, my home, my savings, my husband, my self-worth, and most of all, my love for life. At our department, we also performed focus groups. And here are some quotes. My appearance has changed and has not had a positive effect on me. I don't like the fact that my face has changed. I envy friends who look feminine, and I envy friends when they get children. I have gone through a lot of sorrow in the last couple of years. All this because I discovered that I wasn't myself anymore and I couldn't do things that I could do. So all very illustrative quotes of the impact of acromegaly. What we did is we audio taped all these conversations we typed out all these conversations, and then we analyzed the text. And based on this text, several themes and subjects raised. We categorized these subjects into the biopsychosocial model. So all physical complaints together, all social complaints together, and all psychological complaints together, which I will discuss now. So here are the physical complaints. Physical complaints reported by patients were pain, sleeping problems, changed physical appearance, cognitive problems, as we already heard today, concentration, attention problems, memory problems, and problems in executive functioning. Sexuality problems, as well as a physical feeling of tension and fatigue. This was physical, but patients reported also a psychological feeling of tension and fatigue. Other negative feelings were shame, sadness, jealousy, frustration. Psychological complaints such as fear of recurrence. This was a frequently reported complaint, and this is also seen in patients with cancer. So the fear that the tumor will come back or becomes more active. Those patients reported also worries, panic, stress. Personality issues, feeling that their personality changed, emotional functioning changed, lowered self-esteem, and they were more easily irritated. Sexuality, decreased libido, and issues with the desire to have children. And social problems. They reported issues in social functioning, difficulties in communication about the disease, a lack of sympathy of their environment, a negative influence on their partner relationship, a reduced social network, and they reported work-related problems and problems in leisure activities. Well, besides these biopsychosocial problems, patients reported also unmet needs. For instance, they reported dissatisfaction with other aspects of medical care. For instance, what are advices for lifestyle, or is there a physiotherapist for helping me for physical training or psychological care? So, to summarize, patients with acromegaly use less active coping strategies. They report effective illness perceptions. These illness perceptions correlate with quality of life. Characteristics of patient drawings correlate with illness perceptions and quality of life. And focus group conversations and interviews elucidate the patient perspective of quality of life. Then we go to interventions. Well, in literature, interventions have been evaluated, and then the effect of quality of life have been studied. So, as we've heard today, surgery or pharmaceutical interventions improve quality of life. Some studies also evaluated the effect of growth hormone therapy when a patient becomes growth hormone deficient after treatment, and here also positive effects have been found. So these are all biomedical interventions. But as I discussed, patients also reported the psychological and the social complaints. So based on that, we thought, well, maybe we should organize a program which also pay attention to these psychosocial problems. Well, in health psychology, a frequently used matter is self-management. And self-management is defined as the individual's ability to manage the symptoms, treatment, physical and psychosocial consequences, and lifestyle changes inherent in living with a chronic condition. And efficacious self-management is the ability to monitor one's conditions and the effect to the cognitive, behavioral, and emotional responses necessary to maintain a satisfactory quality of life. So here becomes the link between behavior and quality of life. So based on that, we thought, well, maybe with a self-management program, we can address these unhelpful illness perceptions, and we can encourage patients to use more active coping strategies, with the ultimate goal, a further improvement in quality of life. So what we did is we developed a self-management program, and it was called the Patient Education Program for Patients with Pituitary Disease. And this was based on an already existing program which has been evaluated in patients with Parkinson's disease and Huntington's disease and has been found to be effective. It consists of 8 sessions. First is information, then self-monitoring and health promotion, stress management, management of anxiety and depression, and social competence and social support. And then there is an eighth session, and that evaluates the previous 7 sessions. And in this way, we first look at what is the problem, why is the problem, how do you feel about that, what can you do about it, and how can you do that? And in that way, you come from understanding to management to individual coping behavior, with the ultimate goal, a better quality of life. And this program occurs in groups of 5 to 7 patients. And I will not explain every session in detail, but because fatigue is the most frequently reported complaint, I will just give you something we do during fatigue management in this program. I will walk you through this picture. So here you can see time on the horizontal axis and activity on the vertical axis. So when we first look at the black line, you can see a patient is feeling well. Then he or she is going to do a lot of things because he or she has a lot of energy. And afterwards, and then a patient is in their peak load, and afterwards someone is exhausted. And when someone is exhausted, he or she has to take an involuntary rest. So he or she is pressed to take a rest. Well, after this rest, there's again energy, patient is feeling well, is going to do a lot of things, again peak load, after that peak load, again an involuntary rest because the patient is exhausted. And when you follow this pattern, in the end there will be less well-being, but more importantly, a patient is actually a victim. He or she doesn't control his or her own life. While we look at the green line, which we aim to promote during the program, we say, well, you're feeling good, you're going to do a lot of things, and then you plan in a certain rest moment. So you take a voluntary rest when the patients want to, then you're going to do several things, then a voluntary rest, and so on. So what you can see is that in the end, there's more well-being, but more importantly, a patient is the director of his or her own life. So he gets more control on her or his own life. And the principle might look simple, but it's frequently an eye-opener for patients when they see this picture. We are working on a randomized controlled trial with this program, and we are currently collecting the last data. So I can't present you the results of the study, but we ask patients, well, what do you think of the program? And 67% said that they experienced the exchange of experiences helpful. 68% reported that the program was appropriate, and 83% recommended the program to others. So I think, in general, a positive evaluation. So then I come to my take-home message, and again, a picture of a sculpture made by an acromegaly patient, and again, I think it's a very illustrative picture. We can conclude that patients with acromegaly have impairments in quality of life, even after long-term remission. They report effective illness perceptions. They use less efficient coping strategies. They report some unmet needs. And we think that a self-management program seems to fit in to these unmet needs, at least partly, and might lead to a further improvement in quality of life. I would like to thank all the co-workers, and I would like to thank you for your attention.